Good afternoon, everybody. Welcome to the VCU Department of Internal Medicine Grand Rounds. Today's session is sponsored by the Division of Hospital Medicine. Today's title is Past, Present, and Future of Hospital at Home. We're pleased to have Dr. Linda DeCherrie here. Before I introduce her, just a couple of housekeeping items regarding Grand Rounds. Everybody remembers now you can ask questions throughout the presentation using the chat, the Q&A feature, or you can ask to be unmuted and we can help facilitate the Q&A session at the end. If you have any technical issues, please send myself or Thomas a chat message and we will help you with that. And the CME code will be posted now and at the end of the session for your CE credits. Also, a link to the ongoing Department of Medicine Grand Rounds survey will be posted in the chat. Consider after the Grand Rounds to fill that out so we can improve the content for next year. So, as I said, today's session is sponsored by the Department of Hospital Medicine here in Internal Medicine. And Dr. Linda DeCherrie, she is a clinical professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. She graduated from the University of Chicago in 1995 with a major in history, philosophy, and social studies of science and medicine. She then continued at the Pritzker School of Medicine, graduating in 1999. She completed her residency in internal medicine at Boston University, where she was named chief resident, went on to Mount Sinai, completed her fellowship in geriatric medicine in 2005. Her professional passion is in home-based medical care. She's currently the vice president for clinical strategy and implementation at Medically Home, which is a technology-enabled services company that provides all the essential tools to allow medical providers to provide hospital at home. Previously, she was at the Mount Sinai Health System for 18 years and was the clinical director of Mount Sinai at Home, the home-based service line. That service line included Mount Sinai Visiting Doctors Program, the home-based primary and palliative care, hospitalization at home, rehabilitation at home, Mount Sinai Palliative Care at Home, and pediatrics visiting doctors and complex care. Thank you, Dr. DeCherrie, for being here. I'm going to turn it over to the Geriatric Division Chair, Dr. Peter Bowling, to give a couple of remarks. And we also want to thank Dr. Alan Dow, the Interim Chair for the Division of Hospital Medicine, for inviting Linda to today's talk. Peter?
Thanks, Christian, and welcome, Linda. We were just at the start reminiscing, trying to figure out when I first met Linda. I had been making pilgrimages to New York City to work with the visiting nurse services up there and the Mount Sinai Visiting Doctors Program for quite a few years, back when I had a lot more hair. And Linda and I met when she joined that rapidly growing program and quickly rose to leadership there. And then has since really blossomed into a nationally recognized leader in home-based medical care in a variety of ways. A large CMMI grant, a randomized clinical trial of home-based primary care, and now rapidly advancing work in hospital at home. I'm really looking forward to hearing what she has to say and thinking back on how it was way back when.
Thank you both for that wonderful introduction. I'm really happy to be here today. I'm going to share my screen. Hopefully everyone can see that. So today I'm going to talk about hospital at home, which is the thing I am most excited about right now. We're really at a precipice. One of the small silver linings of the pandemic is, I think, hospital at home was pushed a little further and at kind of an exciting time. I want to first acknowledge that a lot of my work when I was at Mount Sinai was funded, as Peter mentioned, from CMMI and the John A. Hartford Foundation. They've been very instrumental in my work for many years. I'm currently a full-time employee of Medically Home, and I'm going to talk about hospital home in a very general sense and not a specific company stance on anything, reflecting on my time at Sinai and my current position. So why do we need hospital at home? And I always go back to when I was doing home-based primary care, and I would go to someone's home and see them And I would know, and they needed to be admitted, and I would know I could clinically take care of them, but I would be frustrated with the inability to get IV antibiotics without a prior authorization, which would take 48 hours. And then he couldn't really get a visiting nurse to go more than, twice a day to see a patient. And that's really where a lot of this frustration of knowing that we can do this, but how can we coordinate it? And then how can we pay for it? So this is one of my patients, and she was 82 and she lives in the same building as her daughter. I'm coming from New York City where that would be common. And she's alone at night, but she does have an aide with her during the day. And she has multiple chronic conditions. She's on a number of meds, and she's had multiple admissions before, most notably for dementia and CHF. But this time she's presenting with pneumonia. And she says, you know what? I don't want to go back to the hospital. I don't like the food there. No one really talks to me. One time she remembers vividly that she got confused and was tied down. And she always comes home with a new set of meds. And I can't sleep there. And those are all reasons, that we know what happens in the hospital, and how can we do this better for this patient for this kind of condition. So today I'd like to, this may be ambitious, but to talk a little bit about the history of hospital at home, my experiences, what this really looks like, and then what are challenges, outcomes, and what you can think of once you've established a program, where you can go eventually with it, and then some comments on how to think about starting programs. So hospital at home is not a new idea. This has been around decades in other countries. Australia, Israel, Italy, France, Spain, all have fairly robust, or England, very robust hospital at home programs, taking care of patients who need inpatient level care. In the mid-90s, we credit a lot of the American model of hospital at home to Bruce Leff at Johns Hopkins, where he started in the mid-90s a program there. And this is publications from him at that time, where even in a research project with the long IRB consent, 61% of patients chose to do hospital at home. They showed that it was feasible and efficacious with high quality care, fewer complications, higher satisfaction, lower cost of care, less caregiver stress. I think that's interesting to think about. Some people worry that this is putting more stress or more work on the caregiver, with better functional outcome and also higher provider satisfaction. I think that's very important to think about as well in the pandemic right now, where there's a lot more burnout. One other notable place is Presbyterian in New Mexico. They also started not soon thereafter, and they have an integrated health system. And so they basically hospital and payer combined, and they were able to do a hospital at home program since the mid-90s and continue it today. They're one of the longest running programs. And they were able to show 19% lower costs. Some of that related to a shorter length of stay with lower rates of procedures and tests. These are some meta-analyses that have been done, and I know that you can't see the details of that. Many of these are in Australia, where they have extremely robust hospital at home programs. But you can see mortality with a number needed to treat of 50. That's pretty incredible. And a 24% reduction in readmissions doing hospital at home. And the Australian model is very close to the American kind of general models. And in fact, they are saying in Australia that basically they are not building as many hospital brick and mortar buildings because of this. They reimburse the same as inpatient care to the hospital at home programs. And so with that, they've not had to build, as I said, as many physical buildings. So after the mid 90s, early 2000s, really what had been happening was the VA was able to create hospital at home programs, different payment system, also robust home-based primary care programs, which were very tied to their hospital at home programs, and a few integrated health systems. But again, it really got stuck with payment. A couple places were trying with their ACO population, but still challenging. And so then we get into my experience with hospital at home. And I explained how I came from this background of home-based primary care and knew we could do this. I talked to Bruce Leff many times. And when the opportunity came about in 2013 to apply for a CMMI award, a group at my institution got together and wrote that. Never thought we'd get it. We're very fortunate to have received that. And that is where we started with the Medicare fee-for-service population, a hospital at home program at Mount Sinai in New York. Again, built off our visiting doctors program. We started that program. We called it the Mobile Acute Care Team. That name does not resonate. Patients, families didn't understand what that meant, and we had changed it to hospitalization at home later on. But at that time, it was the Mobile Acute Care Team, and we operated that with that CMMI award for 3 years and got a lot of great understandings of what we could do. And I'm going to go into a little more detail about that on the next slide. But just to go on with the timeline here, we merged all the home-based programs at Mount Sinai under one service line. We spent a lot of time after that thinking about how to scale, how to disseminate this. And then right when the pandemic started, we started a program called SIHA, which I'll also go into more detail, completing hospitalization at home. And then the excitement about the Medicare waiver in November of 2020 that we were one of the first at that time to receive that, and did meet with Medicare many times in their design of that. So at Mount Sinai, when we envisioned our CMMI award, we thought about what could we do that added on, or what was really needed to think about how to develop our hospital at home program. And part of that CMMI award, the application process, part of the request was to think about a payment model that you could design afterwards. And so what we designed was not only an acute period of time you would take care of the patient that mimicked the hospital. That was basically, a lot of work based on Bruce Leff, but also what would be needed to do really good transitional care, post-acute care for patients, to avoid the readmissions and help them try to get back to a new baseline or their baseline after the hospitalization. Knowing that if we could design a payment model that would take financial risk on the 30-day episode, that could potentially be a model that health plans would be interested in, and we could do the right care for the patient. As we know that discharge from hospital, no one is always all better at that moment. And so how can we do robust transitional care? So what we designed was a program that would take patients from the emergency room and do eligibility and understand their home situation, transport them home, verify that their home is safe at that moment, provide acute care to the patient, which included originally all in-person provider visits. This was 2014, where we weren't as robust with virtual care. Of course, all the IV medications, oxygens, X-ray labs, 24/7 support. We had paramedic support, and then you would discharge them and move them into this post-acute time, where we would include nursing, PT, We could do home visits or paramedic visits if there was a reason to do that during that time, and really try to get them stabilized and back connected with their PCP and any other specialists. Then, as I mentioned, at the time of the pandemic, this work I'm very proud of. New York, issued the state of emergency in March 7th, 2020, and we were able to, within really a week, have all the administrative approvals to be able to take patients who are already in the hospital to finish their hospitalization at home. Some people call this reduced length of stay. It's not really that, because of course they're still in the inpatient, but now at home setting. But this allowed us at Mount Sinai to really decant the hospital at a crisis moment. So we took patients basically the same as you may have heard. There were tents in Central Park, same level care as those tents, and we're able to bring patients home. And as soon as more PPE was established, we even took COVID positive patients, and that program still exists today. Most places, because when I get to what the current Medicare waiver allows, most places today take patients both from the emergency room and from the inpatient units to finish their days at home. And then a pretty exciting day was in November 25th, 2020, where Medicare agreed to cover hospital at home the same as an inpatient stay, the same DRG reimbursement for the duration of the public health emergency. And so this is an individual waiver. That means an individual hospital has to apply. There's an interview process and then be approved to take patients and get reimbursed in this way. And what was fundamentally different than what we had done before was this now means that that patient is actually in the hospital at home. Previously, legally, most hospital at home programs, including at Mount Sinai, they were outpatient physician entities providing inpatient level care, but legally an outpatient physician entity. Because you couldn't be the hospital, you couldn't meet all COP requirements. But now this specifically, the waiver waives the 24/7 on-site nursing requirement, and instead puts new requirements on of number of touch points and other pieces for the duration of the public health emergency. Right now, the public health emergency goes until mid-July. They must give us 60-day notice prior to discontinuing it. But I'll talk a little bit more about that in a second. So what does the waiver specifically require? So as I mentioned, instead of 24/7 on-site nursing, they must have 24/7 access to the care team, which must be immediate. That would be like a phone call that immediately, or a video must be immediately gotten to someone on that care team with an emergency response in less than 10 minutes, let's say to escalate to a physician, and an urgent response pretty quickly thereafter in the home. You must be able to provide services that would have been in the hospital: pharmacy, infusion, respiratory, diagnostics, monitoring, transportation, food, DME, anything that the hospital would require. And you have to do all the same metrics that a hospital. A fall in hospital at home is a fall that needs to count towards your hospital fall metrics. There must be care by the same care team. So there has to be physician-led daily rounding with 2 touch points a day in person. The physician rounding does not have to be in person. That can be video visits. but there must be at least two daily in-person touch points with a nurse or paramedic. And if it's done by paramedics, then there must also be a nurse care plan. A nurse must see the patient virtually to provide that full care plan. And then as appropriate for that care plan, there must be available physical therapy, occupational therapy, speech therapy, social work, aides, couriers, all the things that we don't usually call it, we call it transport in the hospital, or, you know, the tubing system, but the equivalent, all those things, which is a courier for the home, need to be available to patients in the same way per the CMS waiver. And so just to be clear, that means that whole post-acute time is not covered under the waiver. And so many health systems right now, as they're quickly standing these programs up, they are thinking about acute only replacement. You know, that's an important first step. I still would encourage everyone to think about how we can do this better for patients, and think about that transitional post-acute time. And that's really where, once you're in the home, you're going to be able to really make big changes in these patients' lives. So you really might be wondering, what does this really look like? How do you actually do this to care for patients? And so the two entry points are, unfortunately, I'm very clear, unfortunately, are still the hospital. Even though we're trying to avoid hospitalizations, the two touch points by the waiver are the hospital. They must either come from the emergency department or already on the hospital floor and in a reduced length of stay, CHA-like manner. I will say again, when you negotiate a reimbursement from a payer, and at Mount Sinai, we had done that, you would also include other potential places to admit patients. For example, the cardiology practice was a very great place to get identify patients from. You know, they would often have the ability to start IVs, put, you know, a couple doses of IV Lasix in the CHF practice, and then they, you know, are not better yet, would need to go to inpatient level care, and we would be able to admit them right from the cardiology practice. But that is not approved under the CMS waiver, and would only be able to do it if you had other contracts. So I'll focus on the CMS waiver, which is these two touch points. So usually health systems at that point have a electronic screening process that identifies patients in the emergency department or the floor who meet insurance criteria, age over 18. You would define a geography you're working in, so those zip codes would be loaded in, and that you can potentially already add some other things into that algorithm. Currently, I don't know of a program who's doing hemodialysis as part of this, so that could be if someone has existing known hemodialysis, that could already be electronically screened out. And you get a list then of the patients. And programs have different types of staff members, but someone would then be starting to review those patients for clinical stability, and eventually, when maybe the list is a little more narrow, pass that on to a physician or an APP who would then really be like, okay, yeah, this patient clinically looks really good. Let me get on the phone with the ED doc and understand what's going on with this patient. And then if that all seems really good and ED doc agrees, or the discussion is positive, then someone needs to do a social stability assessment of the patient. And this is fairly simple. It's like running water, electricity. Do you have a home? and then usually an understanding of what their home situation is, because then if they don't have enough assistance in the home, the program could add home health aides and other things to make the patient safe at home, and make sure you understand the meal requirements and so forth. And then if that all seems to work out, then it would be obtaining consent from the patient. Of course, these are currently all opt-in, and then they're transitioned home. And that first, usually because of the way admissions work, it's usually the evening at this point. That first evening, someone from the care team would be at the patient's home to confirm that home is indeed appropriate and that everything is safe for the care. Many programs have tech involved, some don't, but that would be the time to set up the tech and make sure everything is all ready. And then the next day, a typical patient would have, as I said, at least 2 touch points, but usually it's many more, because in reality, it's the phlebotomist stopping at the door, and then the courier maybe to pick up the blood later. Maybe there's an x-ray tech has to come to the home, then the nurse or the paramedics coming to do an infusion, then there's the video visit with the physician. There might be APP visits as well in this to complement, to do some hands-on physical exam that cannot be done virtually. Usually programs have APPs involved in that, and other deliveries. And then they would be discharged like any other inpatient would be, and moved on to this restorative, post-acute, transitional phase, if that is something that is covered under that plan. And then transition to the PCP during the restorative and ongoing. So I've talked a lot about the program, and I'm sure when we have the Q&A, there'll be more questions. I didn't talk about kind of the behind the scenes part, and I don't want to neglect that there's, in addition to all the patient facing, there's quite a bit usually of team rounds involving many disciplines in the health system. So social work's a key part of this. Pharmacy is a really key part of these programs, and care management, and or whatever, social work, care management, discharge planning, care navigation type roles are all really important in rounds that usually happen daily in the mornings before all the in-home visits. So the first real implementation challenge, and somewhat more stable now that we have the waivers, what is hospital at home? It has elements of home care, but we're not home health. We certainly have elements of the hospital, and that's really where we're legally in the waiver, at least under that auspices, but there are still elements of outpatient to this model. Very concretely, when I was at Mount Sinai, we started as I said, as an outpatient practice, providing inpatient level care with outpatient Epic. And the next iteration, because you can't do this without patient Epic, because you don't have a MAR and you don't have orders, order sets. And so then we moved on to therapy plans, like chemotherapy orders, which allow order set to go for longer periods of time, but still very challenging. And actually had planned to move fully into inpatient Epic, but yet still an outpatient practice prior to the pandemic. Was delayed a little bit, but went live in the summer of 2020. And that was really the best, to be able to have a MAR that can be documented on, as well as having order sets. And then once the waiver came around and we were able to move things to inpatient pharmacy instead of using outpatient pharmacies, that really helped a lot with some of those challenges. But you have to think about, using, a DME company, that's usually an outpatient. How do you get an order to them from inpatient orders? Like so there's lots of, challenges in how you think this through. As I said, a little bit easier today with most of the framework as hospital, but needs to be thought through. The next is challenging. So this is Times Square in a snowstorm. So every location has their weather or other emergencies. So you definitely need to plan with your health system's emergency preparedness. So what happens if you're a command center, the electricity goes down? What happens if the patient's electricity goes down? What if weather's going to happen? Are you going to transport patients back to the hospital? We put nurses in hotels nearby patients if there's going to be a lot of snow. So, there's, things you have to think about, and how do you get everything? And and things are decoupled that would have normally been kind of automatic. This is one way of thinking about all the things that might need to come into someone's home to be able to provide home hospital. And I'll just highlight 3 here. So when you order a lab in the hospital, you just order the CBC, and then, either your hospital has the nurses or there's phlebotomists come up and they either carry it back down to the lab, or maybe you have a tube system that gets it to the lab, and then it goes to the inpatient lab, and then that lab processes it, and it results in Epic. But you only did one thing as the physician, and that's the goal, I think, in most hospital home programs, to still have the physician only think about one thing. But you really have to break that down in the same way. So who's going to draw that blood? Is that going to be the nurse? Does that time of the nurse's infusion match up with the time that makes sense for the phlebotomy, or should we get a phlebotomist to go? How are you going to get, is it most efficient for the phlebotomist to drive back with that sample to the lab? Or is it better to have a courier come so the phlebotomist can go to the next person? And then can your lab process the blood in the time frame that would be expected of a hospital? Most outpatient labs process blood in a different urgency than the inpatient. So, those are the things that you need to think through as you're setting up hospital at home programs. And the next is scale. And it's really challenging. I would love that we don't have to create lists and look for patients, but instead that the ED doc would say, okay, this patient's for OBS, this patient's inpatient, they need to go to telemetry, this patient's inpatient hospital at home, this patient's inpatient at, regular floor. That would be an ideal state. But we can't do that until every payer that, every patient's insurance that comes to your ED is accepted to hospital at home. Just like OBS now, every payer basically covers OBS or requires to think about OBS. And until we have that, we can't have the ED do that designation. And until, in the meantime, if you rely on them referring, you're like, oh, sorry, they don't live in our geography. Oh, sorry, we don't take that insurance. That ED doc's never going to refer that patient again. And so that's kind of the tricky part, is how do you get all payers so that you can really get to that culture change of what this looks like. And then the next real big challenge is that payment. So right now, there is the CMS waiver till the end of the public health emergency. There is legislation introduced both on the House and the Senate side to extend the waiver for 2 years beyond the end of the public health emergency. That is moving along. And I think that, of course, both the House and the Senate have a lot of other priorities, but how to get in front of them and get everyone to have that move all the way through to execution is still going to be a lot of work. And so then the really big thing is that every place that wants to really have a robust program needs to think about the payer contracts. And my bias is towards 30-day episode for that, those contracts. I'm going to go just a little bit of outcomes. I showed you some in the very beginning with the historical work. These are some of the outcomes when I was at Mount Sinai that I was part of. Again, what we were fortunate enough to not only have the CMMI award, but we also had the funding from the Hartford Foundation, which allowed us to have identify patients. So this was not a randomized trial. This was patients identified in the exact same way at other hospitals that we did not offer hospital at home at, or on weekends, which we didn't admit at that time, on weekends at the main campus, but identified in the same way and followed. And again, these outcomes are part of patients who not only got acute care, but also had the post-acute transitional care. And you can see here they had a shorter length of stay. You know, a discharge doesn't become so difficult. Sometimes that last day of the inpatient is trying to get everything arranged and set up to get them home. And here they are at home already. But you can see the big drop in all-cause readmissions, similarly drop in the ED visits with higher experience ratings and much lower discharge to skilled nursing facilities. Flip side, many did get more home health episodes, but less skilled nursing facilities. And then this is from our first 30 days of the CHA program during the initial COVID crisis. So these are patients between March 19th and April 18th. And even with 24 patients, there were 75 potentially averted hospital days, beds that were opened up at that time just because beds were needed for COVID. But if in the new world or not post-COVID, but post-COVID pandemic at least, that is another way to think about, do you have a reason for expanding some other part of your hospital? Are you bringing, a new surgery and a bigger oncology program, something like that, where you could use hospital at home to help patients from Gen Med potentially do their care at home to open up for other care that can't be necessarily provided at home. So when we applied for our CMMI award when I was at Mount Sinai, we thought that was all we were going to do. Hospital at home with a 30-day episode. That's what we wrote. That's what we were going to do. And we were thinking the typical Gen Med, UTI, pneumonia, cellulitis, CHF patient. And we quickly realized that as soon as we built this and on our platform of home-based care, either we were asked to do something different by people that are like, refer a patient, oh wait, couldn't you do this? Or things changed. So the first was OBS came into existence. That really wasn't when we wrote the grant. And so we did a small modification with our CMMI officer, and we were able to do OBS unit at home. That's not covered currently under the CMS waiver. I just want to be very clear about this. This was at the time of our grant, but we did do OBS at home, not cardiac, not telemetry, but there were many other cases where you're needing someone to be OBS at home, and we provided that. Another thing, I came from a department of geriatrics and palliative medicine. That's who our docs were. This wasn't initially out of the hospitalist group. Mount Sinai has transitioned now to really coming out of the hospitalist division. But we we started caring for patients who would have otherwise been in our inpatient palliative care unit. And that was, I think, a really nice addition to the program. Patients who either this was the moment of crisis and hadn't really engaged in goals of care conversations, we could take them home and do those intense goals of care conversations, and transition them to hospice at discharge if that was what was needed. So that's something else to think about. Then there's a population of patients who would have never gone to the hospital, to think a little bit about that care, and you know, again, not covered under the CMS waiver because they must go through some part of the hospital, but that was something we were able to do in our CMMI time. Most hospital home programs don't admit 24/7. There's usually some cutoff later in the evening, and then pick up the next morning. So how do you capture those other patients? And we use the EDPAs to help us hold those patients till 8 a.m. With agreement with the whole health system to identify those patients. We did a small trial with pediatric hospital at home. That's very challenging. Nursing skills are needed at different age groups. But we had a pediatric home-based primary care program who provided the pediatricians for that. I mentioned the completing hospital stay at home. And then we also moved into not replacing hospital care, but replacing subacute care at home. Very popular with patients who didn't want to go to skilled nursing facilities. And it's something that you can think about adding on to your hospital at home once your rapid response platform is really created. And then I think really currently in the world of hospital at home, these are the populations that are being contemplated or just started with different programs. So many programs do take oncology patients, but really thinking about how to expand that. How do you go more upstream, talk to patients before they're scheduled for a particular chemo or transplant, and then making the expectation that, if unless clinically unstable, the plan would be to come in for X number of days and then transition for the rest of the hospitalization at home. Similarly, surgeries. I mentioned that I don't know of any places doing center-based dialysis patients, accepting them into hospital at home, but I think that's something to still think about. Places do take home hemo patients in hospital at home, and PD definitely, but thinking about that. And then I mentioned SNF and PEDS, places are thinking about. So my last couple comments are about starting up a program and what is that going to look like. And so just a good assessment of your health system capabilities. What is under your umbrella with regard to home health and paramedics and DME and phlebotomy and all those pieces. Try to understand what you have to insource versus outsource. Really important is a C-suite champion, because this will touch every department in your hospital. I thought I knew Mount Sinai when I started the hospital at home program. I'd already been at Mount Sinai for 10 years, and I knew the outpatient world, but I thought I knew a lot because I had been a fellow there. I'd rotated inpatient, all of that. No. You get to know dietary leadership, pharmacy leadership. Everybody is involved, policies and procedures, nursing leadership, everybody is involved in these programs. And you need to have really that C-suite champion to say, this is a priority of our health system. We're going to do this. And we need to figure out how to make it work. And so that's really important. Apply for the waiver. That's definitely a way to get started. And then really thinking through what is the problem you're trying to solve by starting a hospital at home program. I put a couple things here and to make sure you have the why very clear, and so that can be articulated throughout the health system. And I'll put in a plug for the Hospital at Home Users Group. This is a organization that 4 of us started with the John A. Hartford Foundation funding to help disseminate best practices of hospital at home. It has, we have webinars, we have tools on the website, and a online kind of presence where you can ask questions to the whole community and get responses from other people in the hospital at home community. So that would be a resource that I really encourage everyone who's wants to think about these programs to get involved in. So hopefully I have about 10 minutes now to answer questions. And thank you.
Thank you, Linda.
Yeah.
Really appreciate that. It was really wonderful talk. We have a couple of questions. I just want to introduce one additional person just to shed light on some things happening here at VCU for the audience. And so I would like to introduce Dr. Julia Siegel Breton. She works with the VCU Continuum Integration Center as the medical director and has been integral in the work around VCU Health at Home in collaboration with Ryan Rasig, Jay Holdren, Dennis Morales, Allison Napstein, and all the wonderful people at the Continuum Integration Center and Senior Services. Obviously, Dr. Peter Bowling, Dr. Alan Dow, but Julia, I want to turn it over to you for a second.
Thank you. Well, first of all, thank you so much, Dr. DeCherrie, for your leadership nationally for hospital at home and for the expert advice you've shared with us. And second of all, I wanted to announce to everyone here today some hot off the press news that VCU Medical Center is now, as of Monday this week, an approved hospital for the acute hospital care at home waiver by CMS. And as described in this Grand Rounds presentation that you just heard, the hospital at home program really epitomizes the quadruple aim and will be essential to meeting the needs of our patients, the health system, and the community by adding meaningful access to serve even more Central Virginians by combining VCU Medical Center's exceptional talents in hospital and in community-based care. So thank you so much, and back to you, Dr. Bergman.
Great news. Congratulations to all involved in that project.
Yeah, that is great news.
We have a couple questions. I'm going to start with a question by Dr. Nasifa Hussain. Thanks for the talk. When you talk about taking patient from the hospital, what does it mean? How is it different from home health, IV antibiotics, hospital care at home? Any thoughts about that transition from the hospital, getting care to the home? I think this was referring to completing the hospital stay at home, perhaps. Any thoughts?
Yeah, that's a great question. So it's really, if the patient was ready for discharge and you could refer to home health, then the patient should be discharged and referred to home health. That would not be a patient you would consider for hospital at home. But if there's a reason for the patient to still be admitted, you are still figuring out the right dose of something, you are still monitoring daily or twice a day labs, those kind of things, or you feel like this patient needs that vital signs multiple times a day still, those are all reasons why you would keep someone in the brick and mortar hospital, that you could consider having them finish their care in your hospital at home program. So you really need to just really consider, like today, before you have your hospital at home program, what would you do with this patient? Are they going to stay or are they going to be discharged? And that would be the same kind of decision that you need to think about. And I use that same analogy in the emergency room, where it is hard to wrap your head around this sometimes. And emergency room docs will be like, well, I'd like them to be monitored a little bit more, but I wouldn't, if you weren't here, I wouldn't have admitted them. Then that patient doesn't meet, inpatient criteria. They wouldn't be admitted, then they wouldn't be going to the hospital home program.
Thanks. The second question comes from Dr. Brian Castle. You may get to this later, but just in case, do any of the hospital at home services you described in the episode of care, blood draws, x-rays, infusions, can they be performed by subcontracted vendors such as Dispatch Health or similar? Dispatch Health here is our urgent mobile urgent care vendor. Any thoughts?
Yes. So the hospital in the waiver, and if you were to do this with other insurances, can subcontract care. The patient, the health system, the hospital is still responsible ultimately for that care, but you can create contracts to have others provide that care. And I would say I don't know a health system that has absolutely everything that you need for a hospital at home all under their umbrella. Everybody does subcontract care. So that could be the in-home nurses, that could be the x-ray, that could be the phlebotomy, that could be the DME company. Yes, but you have to create those contracts, and the hospital is responsible for that care. Meals are another one. Sometimes the inpatient dietary meal service gets delivered to the home, but most often an outside vendor is providing meals for the patient.
Thank you. Additional question here. Do the teams, I think this is referring to the provider teams, medical team, select certain treatments, daily or BID antibiotics, Q6 infusions, stay away from Q4 nebs, in order to ease the care required in the home?
Yeah, very good question. And I think different hospitals use different, have different services or different ways to answer that question. One example would be, for example, if you were doing a BID vanc infusion and the patient arrives at 11 a.m., they get their first, vanc in the ED at 1 p.m. And certainly you need to be able to provide 24-hour services to that patient, but is 1 a.m. The best time for the next dose of this patient? And can that be thought of in a different way? And this is where pharmacy can be very helpful. And, is there a way to do an extra bolus dose? Or is it acceptable to do it, 1 hour early, and maybe you have nursing that goes to the home, scheduled nursing. Everybody, as I said, needs to have 24-hour services available, but you can have certain parts of it as the more common core team till midnight. So yes, you do have to think about those things. I would say it would be best to have the physicians think the least about that. I'm a physician, but like when I write an order, I don't think about what is the antibiotic diluted with. I don't think about necessarily the timing of when the first dose was and when the next is. I just write, I need, Q12 hours something. And so you really want to make sure others are helping in that and figuring that out. Q4 hours, probably not done that often, but certainly Q6, so you just have to get the nurse in or the paramedic in 4 times a day, would certainly be, many programs would have that capability.
Okay,
There was another, there was nebulizers also. So you can make assessments on that. So certainly patients take oral meds without a clinician in the home. Many programs do have nurses witness that on video to be able to document that. So similarly, for some patients, you might consider a nebulizer or something that could go in that category, but there might be a more unstable patient. You may want to have a clinician be doing that nebulizer.
Great. We have lots of great questions coming in. I think we have time for a few more here. Dr. Alan Dow wanted to ask if you could talk about the process of engaging patients and families in the enrollment, being admitted to hospital at home versus physically being in the hospital.
Yeah, it's an excellent question. And I think that this is, so first of all, when you are getting ready to go live with your program, there needs to be a lot of education for the entire health system. Because you want the ED doc, you want the ED nurse, you want anyone who that patient may be like, oh, wait, I just heard about this program that they just came to my bedside about. What do you think? You know, and they say that to the nurse's aide, to the whatever. And that other person says, I've never heard of that. Your patient is not going to go with the program. So you need to do a lot of education with the whole health system about it. They don't need to be experts, but they need to know that this is an established program. Like there's an OBS unit, there's a telemetry unit, there's hospital at home. That's really important. And then there are going to be patients who say no. That's going to happen. I can say anecdotally, patients who pre-pandemic, I'll start pre-pandemic, patients who had never been in the hospital before assumed the hospital was always better and would have a harder time. Patients who've been in the hospital before and have seen some of the challenges that they can face in the hospital are often more interested in a program like this. The pandemic has shifted things where patients had experienced not being able to be with their loved ones during COVID, or realizing that, you know, you can be exposed to other things in the hospital, that has shifted this a little bit more in the favor of hospital.
Okay. Dr. Ruchi Desai, are there any thoughts about oncology care at home? You know, we often admit patients for planned chemo, though could often be given in an outpatient setting with an infusion room monitoring. I think you had mentioned that about future populations.
Yeah. I mean, I think you kind of have to start with what is today approved by insurance or covered, and that is you know, that is a moving target. But certainly, let's talk about like stem cell transplants. Like there are some patients who are healthy enough with the insurance that approves outpatient stem cell transplants, and that should continue. They shouldn't get hospital at home. But when someone has more complex health history, and they need more monitoring, that might be someone who could be perfect for hospital at home, because a lot of that is often the transplant, and then you're watching counts go up and down and being able to intervene very quickly when you have that neutropenic fever. And that is, you know, a reason for patients being in the hospital, and can be really sorted through well in hospital at home, especially since usually the paramedics or the community nurses carry meds with them, including antibiotics, so they can really get that, you know, that I'm not sure, is it 1 hour, 2 hour requirement after identification of neutropenic fever that you want to get meds in, can be met for those patients.
We have time for one last question. This one's from Megan Sutton. She's a nurse practitioner here in our geriatric division. Wondering about patients that have cognitive issues or no families. You mentioned that as a screening process.
Really important question. So a majority of patients in hospital at home do have someone with them. It is not a requirement, but cognition plays a role into that. So there are many patients, maybe like my first patient I described there, who have an aide with them during the day. They have some dementia, and at night they are alone, but maybe there's a family member in the next building or something like that. And that's their normal baseline. They are safe in that situation. But now that they have pneumonia, now that they have the UTI, and they might be have risk for delirium, we would say that is not a safe situation for home hospital. So what we would recommend is putting in a home health aide to be with them those other hours, unless a family member wants to be with them during that time, to provide that care. We wouldn't say they couldn't be in the program. We would just have to mitigate that risk in a different way. But a 50-year-old man with a COPD exacerbation who already, lives in an apartment and has a cell phone, who could call us, who can walk to the bathroom, who has meals already delivered or makes meals, who has no cognitive issues, we would allow that person to be alone in hospital at home. But it is on the more uncommon side.
Thank you so much. Any Dr. Bowling, Dr. Syme, Dr. Breton, do you guys have any closing remarks, comments, next steps here at VCU? We're excited about the possibilities and excited for this waiver. So
please keep me informed as to when you launch and take that first patient, and please join the hospital home users group if you're not already.
Dr. Bowling, any closing comments?
Not really, Kristen. I think it's a very exciting time. We've been talking for quite some time about the range of care that can be rendered now in the community, all the way from primary care to episodic care and now to relatively acute hospital level care. Thinking of care at home as a spectrum. I think Linda also mentioned that she had been doing rehab and SNF avoidance care or SNF replacement care. So we're going to see growth in home-based care of various kinds here at VCU as well as around the country. And I'm excited about it. It's been my whole career. So I'm psyched, and I really appreciate her coming and telling the story of her success at that fabulous program out at Mount Sinai and the subsequent work she's been doing with Medically Home. Super.
Thank you so much. Dr. Syme, any comments?
No, I just really enjoyed it. And it's so timely given our new announcement that we're good to go here. So we appreciated your expertise and all you've done. It's incredible. Thank you. I grew up in Scotland, so I'm very familiar with a lot of the home-based things that have gone on there, and really enjoyed that aspect of medical care there. Thanks.
Thank you, everybody. Thank you, Dr. DeCherrie, for sharing. I really appreciate that. And everybody else, thank you. That concludes our grand rounds for today. Your CE code should be in the chat box. Thank you and have a great rest of the afternoon. Appreciate it.